Hello, my dear future nursing officers. I welcome you all once again back to the Master Nursing classes, where the most complicated things are made easy, and very easy for your better understanding and the very best learning. Dear aspirants, now in this particular session, I am going to cover the very high yield MCQs that is having the highest probability to strike in your exam, that is having the highest chance to strike in your exam, and I am going to give you those golden points that you must and should revise before the exams. So this is a very important class. Don't miss a single point from this particular class. Every point what I am teaching here is the very important and the very important for your exam. Please do pay the full special attention from the starting of the class to the completely end of the class, and wherever I am telling this is important, so listen carefully, understand the concept and revise it perfectly. That is definitely going to helpful for you all, and that is definitely going to improve your marks in the exam. So let's begin the session without wasting a time. So very good evening to one and all. Good evening, namaste, namaskar, vanakkam, welcome to every one of you to the Master Nursing classes once again. I hope video, audio, everything is perfect and fine. So can we start the session now? This class is completely interactive. So I will ask the question, you have to throw the answer, because now in a situation of the revision, right? So I will make it very perfect. So you will definitely feel worth at the end of the class. Okay, yes. So can we start now? Fatapat do comment in the chat box. Yes, do thumbs up every one of you. Okay, so let's begin the session. First question is starting with a very easy and very important question. Okay, so here is the very easy question and very important question. So this is not just an important, this is very important question. So from here you may expect a direct question. Which of the following is the earliest clinical sign of the magnesium sulfate toxicity is the question. Okay, so option A is telling loss of the deep tunnel reflexes, B is telling respiratory depression, C is telling decreased urine output, and D is telling cardiac arrest. So what is the correct answer? Everyone, I want answer from the every one of you. Yes, completely focus on the revision, avoid reading the new things, and whatever the updates I am giving to you, that is more than enough to crack your Norcet. Believe in your preparation, believe in you. You can change the things very easily. Otherwise, you will be going to stuck in the things if you are running behind the unnecessary things. Don't run behind the unnecessary things, because we have the very short and perfect time. So we have to utilize this one every second as a gold. Okay. Yes, in the journey of the aspirants, in the journey of the aspirants, every second matters. Okay, so don't waste it, right? Yes. So the next very important thing what I'm going to explain is that is the clinical signs of the magnesium sulfate toxicity. Here the question is asking earliest sign. Your single perfect answer goes to the loss of the deep tendon reflex, and every one of you have chosen the correct answer. I'm very proud of you. Okay, yes sir. Now you consider that we are following the Pritchard regimen to administer the magnesium sulfate. You know, in the Pritchard regimen what we are going to make. So we have the loading dose. In the loading dose we are going to give the 14 gram of the magnesium, right? Yes sir. So this 14 gram how I am going to give? So the 4 gram I am going to give by IV. 4 gram, this is by the IV. Sir, how sir? So IV in the sense here the 1 gram of the magnesium is present in the 2 ml of the vial. So this is the standard dosing of the magnesium sulfate. In the 2 ml vial we have the 1 gram of the magnesium. So here I require the 4 gram. Okay, yes sir. 4 gram I require means how I am going to dilute this one. So I have to dilute this one in the 20 ml as a standard dose. I am going to dilute this one in the 20 ml. Okay, yes sir. So how I am going to make this one 20 ml sir? So here I require the 4 gram, means every 2 gram is every 2 ml is having the 1 gram, means if I take here the 8 ml it means is equal to 4 gram. Is that correct? Every 8 ml is equal to 4 gram. Correct? Right, sir. Because every 2 ml is having the 1 gram. So again 2 ml is the 1 more gram. Again 2 ml is the 1 more gram. Again 2 ml is the 1 gram. 1 more gram. So total 8 ml is equal to 4 gram. Right? Yes, sir. So in this 8 ml, I am going to add the 12 ml of the normal soil. So this is equal to 20 ml solution. So now in the 20 ml, we have the 4 gram of the magnesium sulfate. So this is I am going to give by the IV route. Okay, sir. So total I told we have to give the 14 gram of the loading dose. Now we have given only 4 gram. So next, sir, how I am going to give? So next I am going to give the remaining 10 gram, that is by the IM route. Sir, IM route, how I am going to give, sir? Remember, this is very important. IM route we are going to provide, that is 5 gram in a 1 buttock. 5 gram in a 1 buttock. 5 gram is equal to 10 ml, right? Because every 2 ml is containing 1 gram. Means we require the 5 gram, means we require the 10 ml of the magnesium sulfate. This is the huge amount. 10 ml we are giving the intramuscular. Yes. So we are giving the 10 ml intramuscular, means I am going to add the 0.5 ml of the 2% lignocaine. Okay. So otherwise the patient will say the pain. Okay. So in order to reduce that one, so the anesthetic agent, that is the 0.5 ml of the 2% lignocaine I am giving. Okay. So this 5 gram in right buttock. Okay. So this is in a right buttock. Okay. Yes, sir. Again same thing, that is the 5 gram I am going to provide. 5 gram I am going to provide, and the next one, that is 5 gram is equal to 10 ml. So same thing. Okay. So plus 0.5 ml of the 2% lignocaine. This is in a left buttock. This is in a left buttock. Okay. Yes. Is that clear to every one of you? Total how much we given? Here 5 gram, that is the intramuscular, 10 gram we given, and intravenous 4 gram we given. So this is what we call the loading dose of the magnesium sulfate. Very important. Okay. Yes, sir. Then how we are going to provide the maintenance dose, sir? So after giving the loading dose, so we are going to provide the maintenance dose. Sir, how we are going to provide the maintenance dose, sir? Listen here carefully. So that is maintenance dose of the magnesium sulfate. So this is very important. From here you will get the question. We are discussing about the Pritchard regimen. Okay. Yes, sir. How we are going to provide the maintenance dose, sir? This I am going to provide 5 gram. That is equal to 5 gram is equal to 10 ml. Okay. So that 5 gram is equal to 10 ml. Sir, now this maintenance dose I will give in the right buttock. Then I will give the 4-hour gap. Then I will give the left buttock. Then again I will give the 4-hour gap. Okay. So then I will give in the right buttock. So this is alternatively in each buttock I am going to provide the magnesium sulfate. This one should be continued. This one should be continued till what time I will give, sir? So 24 hours after the last seizure episode. Okay. So 24 hours after the last seizure episode, or 24 hours after the delivery, we can say. Okay. So this is very important. Until this time we are going to provide the magnesium sulfate. So this is very important. You are going to keep in your mind. I hope it is clear. Yes, sir. So now I told here I given the 1 dose of the maintenance and the 2nd dose of the maintenance. So before giving the 2nd dose of the maintenance, so here 4-hour gap I maintained. So in this particular 4-hour gap, before giving this particular maintenance dose, I have to check for the 3 things. So what are the 3 things I have to check, sir? I have to check for the very important 3 things. One is the respiratory rate, right? Yes, sir. Another one is the most important one, urine output. Another one is the knee jerk reflex or the deep tendon reflex. These three things I have to check, sir. If respiratory rate is more than 16 breaths per minute, urine output in a last 4 hours is more than 100 ml, per 4 hours, or more than 30 ml per hours, deep tendon reflex is positive. Okay, respiratory rate is more than 16 breaths per minute, urine output is more than 100 ml per hour, more than 100 ml per 4 hour, or the more than 30 ml per hour, and the deep tendon reflex is positive. Then I am going to provide the next dose. In case, listen carefully. If the respiratory rate is less than 16, don't give the next dose of the magnesium sulfate. Withhold the next dose of the magnesium sulfate. Sir, until what time? Until the respiratory rate comes back to the normal, we are going to withhold the next dose of the magnesium sulfate. Listen carefully, one more time I am repeating. If respiratory rate is less than 16 breaths per minute, withhold the next dose of the magnesium sulfate is your nursing intervention. That is very, very important for the exams. Okay, yes, sir. The next most important thing, the deep tendon reflex must and should positive. If the deep tendon reflex is also absent, withhold the next dose of the magnesium sulfate. Don't give the next dose of the magnesium sulfate until what time, sir? Until the deep tendon reflex comes back to the normal. Okay, yes, sir. In case urine output is less than 100 ml per 4 hours, so then what I am going to do, sir? If the urine output is less than 100 ml per hour, first thing I am going to do is check the patency of the Foley's catheter. Any blockage, kinkage is there, so we are going to check. There is no any blockage, there is no any kinkage. Okay, there is no any blockage, there is no any kinking of the Foley's catheter. Foley's catheter is clear now. Then what I am going to do is very important. Listen carefully. Then I am going to reassure that there is in the normal respiratory rate and there is in the DTR is normal. Only urine output is the problem. So then this dose what I am giving here is the 5 gram. This one I have to make as half. And I am going to give the 2.5 gram. Okay, this is very important. From here you will get the question. Okay, so the normal respiratory rate is there, normal deep tendon reflex is there, only urine output is less than 100. Then I am going to provide the half of the maintenance dose, that is the 2.5 gram I am going to provide. Getting the point? Yes, sir. So this is what I want to convey here. And remember, the old guidelines says the respiratory rate cutoff is more than 12 breaths per minute, and the new guidelines says it should be more than 16 breaths per minute. So as I already told you people in the last update class of the PIH and the other eclampsia, pre-eclampsia, MGSO for update session, so there I have already clearly explained this one. I hope it is clear. Yes, sir. So here is the question. So that is earliest clinical sign. I told the loss of the deep tendon reflex. That is every one of you have chosen correctly. Okay, yes, sir. So the next very important thing is, this is the question. Listen carefully and give the best answer. Yes, the Juspont regimen also will discuss. Don't have to worry about that one. Okay, so the question is here. What is the minimum respiratory rate required before administering the magnesium sulfate safely is the question. Yes, just now we discussed, as per the old guidelines, 12 breaths per minute. This is as per the old guidelines. And as per the new guidelines, very nice of you. Also, that is the 16 breaths per minute is as per the new guidelines. Sir, in the upcoming Norcet, which one you have to follow, sir? We are going to follow the new guidelines. That is the 16 breaths per minute. This is as per the Foxy guidelines 2026. Okay, yes, sir. The next very important thing is this one. So the three things I told, that is the deep tendon reflex. It should be positive before giving the next dose of the magnesium sulfate. Okay, if it is absent, that indicates the earliest sign of the MgSO4 toxicity. And we have to make sure that respiratory rate, it must and should be more than or equal to 16 breaths per minute. If it is less than that, withhold the medication and give the antidote. Okay, and urine output in the last 4 hours, it must and should be more than 100 ml per 4 hours, or we can say it should be more than 30 ml per minute. Sorry, this is more than 30 ml per hour. So this is very, very important. We are going to make sure. If it is more than this, we are going to provide. Otherwise, we are going to withhold. Okay, yes. So the next is why we are going to monitor the MgSO4. Why we are going to monitor the urine output in a case of the MgSO4 administration. Sir, whether it may going to damage the kidney? No. The magnesium sulfate is not going to damage the kidney. The concept is the MgSO4 you are administering, MgSO4, whatever you are administering, this will get excretes by the kidney. This will get excretes by kidney. Means it will goes out of the body by the kidney. If the kidney function is not normal, means the creatinine is high, the blood urea nitrogen is high, and the urine output is low, in that particular situation, this MgSO4 will get accumulate in the body. If it is get accumulates in the body, means highest chance of the toxicity of the MgSO4 is there. So in order to prevent the toxicity, we have to make sure that the urine output should be normal. Getting the point? Yes, sir. So this is very important what I want to explain to you. And sir, why we have to monitor the respiratory rate? Because this magnesium sulfate is the respiratory depressants, and even it may causes the respiratory arrest. So that is the reason we are going to make sure the respiratory rate should be more than 16 breaths per minute. And why we are going to monitor the DTR? Because this is the earliest sign of the MgSO4 toxicity. Okay, so the question is this one: what is the normal serum magnesium sulfate level? So not on magnesium, so this is the MgSO4 level. Okay, so what is the normal serum MgSO4 level? Yes, so what is the therapeutic range? That is 4 to 7 milliequivalent liter. So per liter, this is the very important, and this is the 5-star point I am making. And from here you may expect a question. Okay, and as per the updated guidelines, what happens if it is more than 7? What happens if it is more than 20? So those things is the very important, and that is the updated and changed very important table I am going to show, and I am going to keep in front of you all. That should be in your tip of the tongue. Practice that very best immediately after this class. That is important, so that is you can remember. Okay, so one more very important point I will show finish from this particular slide, and we'll move forward. Okay, so antidote for the MgSO4 is the very important, that is the calcium gluconate. Sir, how we are going to provide the calcium gluconate? Remember the 10 in the administration of the calcium gluconate in the MgSO4 toxicity. What is the meaning of the 10 sir? So that is the 10% of the calcium gluconate we are going to provide the for the duration of the 10 minutes. So 10% is in the sense that is 10 gram in 100 ml of NS. Okay, so 10 gram of the calcium gluconate for the 10 minutes we are going to administer. So this 10 gram, or that is the 10%. So that is for the 10 minutes. Okay, so 10% is in the sense in 100 ml, this is the 10 gram. Okay, so this is very, very important. You are going to keep in our mind. Okay, so I hope it is very much clear. Yes, sir. Here it comes to the very important chart. This is as per the latest updated guidelines. Very, very, very important. So please do keep in your mind. From here, you may expect one question directly in your exam. Sir, what is this one, sir? So this is the serum magnesium level and its clinical effect when it will exceeds the more than the normal. So the normal, what I told, we have the 4 to 7 milliequivalent per liter. This is the normal we have. Most importantly, please do keep in our mind, if it is crossing more than 7, so that is if the 7 to 10, the first earliest sign of the MgSO4 toxicity will happen, that is the absence of the deep tendon reflex, and if it is 10 to 12 milliequivalent per liter, so this is the respiratory depression, and more than 20 after the 24, this is the respiratory paralysis and the cardiac arrest will happens. Then sir, in our competitive books, previous year question books, we have studied sir 10, 15 and more than 30. That is the old, that is the previous year one, that is the old guidelines. This is the new, this is given in the FOGC 2026 updates, FOGC 2026 updates, and in your upcoming all new book also this guidelines is going to come. Okay, so please do keep in your mind, if the serum MgSO4 level is 7 to 10 means what is the clinical effect which happens, that is the toxic effect, the loss of the deep tendon reflex, the earliest sign of the MgSO4 toxicity. 10 to 12 milliequivalent per liter means the respiratory depression will happens, and more than 20 after 24 the respiratory paralysis plus cardiac arrest will happen. So this is very important for the exam. Please do keep in your mind. From here we may expect one question. Okay, yes sir. So here it comes to the next question. So I want everybody's answer. This is important and very important. According to the IMNCI, which of the following is not a sign of the severe dehydration in a child? So the question is very simple. Which of the following is not? These kind of the questions and these kind of the words you are going to focus in the exams. Remember, which one is the least, which one is the most, which one is the not, which one is the except, which one is the except. So these kind of the words are going to change your answers. So read the questions carefully because you prepared for that one, and don't repeat the silly crimes. I will not say the mistakes, I will say that is the crimes, because even you know that is the thing which is going to add the negative marks, and you are avoiding the like capturing the important words from the question. So that is a wrong thing you are doing. Even you are knowing that is the wrong, so that is the crime. Okay, so I will not say the silly mistake. So don't do that kind of this thing. Okay, yes. So capture the a very important word from the question, so that is going to helpful. Right. So according to the IMNCI, which of the following is not a sign of the severe dehydration in the children is the question. Option A, lethargic or unconscious. Yes, the severely dehydrated child will be lethargic and unconscious as per the integrated management of the neonatal and childhood illnesses guidelines. Okay, yes sir. So the child is lethargic and unconscious. It means whenever you will give the fluid to the child, it will not drink a child. Okay, so the fluid it will not take inside. Fluid will be not taken. Even the child is in a dehydration, you are offering the fluid to the child will not drink a fluid, because due to this severe dehydration, the child is lethargic or unconscious. How the unconscious child can drink a fluid? It will not drink a fluid. Okay, so this is a fluid will not taken by the child. This is also a sign of the our very important severe dehydration. Okay, so the skin pinch goes back very slowly. Yes, so the word very is going to very much helpful here. So remember, here is the a classical difference between the three things, that is the no dehydration, some dehydration, severe dehydration. This is most lovable question that is asked by the examiner very frequently. Okay, so this is important for your exam. Please do keep in your mind, that is the no dehydration, some dehydration, severe dehydration. So how to remember this one, sir? In a no dehydration, there is no problem. So there is in the active child will be there, normal eyes will be there, drinks child like fluid you are giving, that is the normally child is drinking, and you are pinching the skin, that is going back quickly. So this is no dehydration, no problem. Okay, everything is normal. Child is active, eyes are normal, drinking normally, skin pinch goes back quickly. Okay, so just here a planning, the home based management and the oral fluid encouragement we will give in the patient. Okay, yes sir. In a some dehydration, so some means some problem is there, not a severe problem. Okay, so in a some dehydration, there is no word called as the like a very word will not come. So in the means is very simple. So let me explain. Then you will understand that one. So in the some dehydration, you will not find a word called as the very, like skin pinching goes back very slowly. You will not see, and very sunken eyes you will not see. Okay, so you will see the sunken eyes, skin pinch back goes slowly, like you will see. So understand here. So in the severe dehydration, you focus on the words. There is in the very sunken eyes, skin pinch back goes very slowly. Okay, and the child is unconscious and lethargic. It will not drink a fluid because the child is unconscious, child is lethargic. Then we are going to provide the IV fluid as a priority, then ORS. Very important. Then it comes to the some dehydration. You see, here the restlessness is there and sunken eyes are there in the some dehydration. And in the severe dehydration, very sunken eyes are there. You can see very sunken eyes in the severe dehydration. And in the some dehydration, only sunken eyes are there. Okay, and in some dehydration, drinks eagerly because the child is restless, but it is conscious. So whenever you will offer the fluid, it will drink eagerly. Dada, 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 it will drink a fluid. Okay, yes. So there is next. Skin pinch goes back slowly here. Okay, so here skin pinch goes back very slowly. Are you able to differentiate this one? Fatafa, do thumbs up in the chat box. Now, can you differentiate this one? Yes. Now, tell the answer for the question. So here the lethargic and unconscious means fluid will not be taken by the child because the child is unconscious. Skin pinch back goes very slowly. So very slowly in the sense that is the, yes, that is the severe kind of the dehydration. And very sunken eyes, this is also severe kind of the dehydration. Okay, and option D is drinks eagerly and the child is thirsty. So this is an indication of the some dehydration. So this is not in the severe dehydration. Okay, so this is the some dehydration. And in the question what they have asked that, so which of the following is not a sign of the severe dehydration? So option D is the a sign of the some dehydration. It is not a sign of the severe dehydration. And who all are you chosen the correct answer as the option D? So I'm very proud of you all. So this is the correct answer. And please do remember, no dehydration, some dehydration, severe dehydration. This is very important for your exams. And here it comes to the next question. Yes. A 3-month child is there. So what is the age group of the child? So this is very important. 3-month-old infant is there. And the child is now having the cough and respiratory rate is 55 per minute. Okay, so cough is there and respiratory rate is 55 per minute is there. But no chest indrawing. There is no chest indrawing and there is no danger signs. How should this classified as per the integrated management of the childhood and neonatal illness? So that is IMNCI. So this is integrated management of the neonatal and childhood illnesses. How you are going to classify this one? So there is only cough is there and respiratory rate is 55 per minute in a 3-month child. So it means the fast breathing is there, but there is no chest indrawing, no danger signs. What is your answer? What is your answer? Yes. No pneumonia means only cough will be there. Only cough will be there. That is the no pneumonia. In a pneumonia, cough plus fast breathing will be there. Cough plus fast breathing will be there. And in the severe pneumonia, cough plus fast breathing plus chest indrawing will be there. And in the very severe pneumonia, cough plus fast breathing plus chest indrawing plus danger sign will be there. Okay, so now you tell me, there is no chest indrawing means here the severe pneumonia chest indrawing is happening. So the child is saying no chest indrawing. It is the not a correct answer C. Then option D, here also chest indrawing is there. So this is also not correct. Okay, Yes. But sir, respiratory rate is 55 in a 3-month child. I am unable to understand whether it is the fast breathing or the normal breathing. Remember, the IMNCI given the cutoff of the fast breathing, this one. In a 0 to 2 months of the child, the breathing more than 60 is considered as the fast breathing, and 2 to 12 months of the child, the breathing more than 50 considered as the fast breathing, and 1 to 5-year child, the breathing which is more than 40, it is considered as the fast breathing. So this is in the criteria of the fast breathing. This is in the criteria of the fast breathing, which is given by the IMNCI. Okay, this is very important. Sir, now our child which is there in the question is 3 months old, and the respiratory rate which we have is 55. So now the 3-month child means between this one, our respiratory maximum should be 50. Now it is 55. It means there is in the increased rate of the respiratory rate is there. So that is I call the fast breathing. Okay, so now I will come to the conclusion that, so here the respiratory rate is 55 means the fast breathing plus coughing is there. Okay, so cough plus fast breathing, which means the pneumonia. The answer for this question goes to the pneumonia. This is very, very, very important for the exam. Please do keep in your mind, from here you may expect one question directly in the exam. Right? Yes. So are you getting the point? Yes. The next very important thing, you can see no pneumonia. In the no pneumonia, only cough is there and cold is there. Cough and cold is there. There is no fast breathing, no chest in drawing. Okay, so here we are providing the home care, fluid, and the follow-up will be there. And in the pneumonia, fast breathing will be there. Cough plus fast breathing. So that is the pneumonia. Okay, severe pneumonia. Cough plus fast breathing plus chest in drawing will be there. Okay, yes sir. And the very severe pneumonia, that is inability to drink and convulsions are there, stridor is there, lethargy is there, plus danger signs are positive. So these all are the danger signs. So along with this thing, cough, cold will be there, fast breathing will be there, chest in drawing will be there. Along with this, the danger signs are positive. So this is called as the very severe pneumonia. Okay, yes sir. So I hope it is very much clear. But in the severe pneumonia, there is no danger signs. In a very severe pneumonia, the danger signs are positive. That is the baby will not drink the thing. Means baby will not breastfeed. So breastfeeding will be not taken by the baby. Convulsion are coming very frequently, and most importantly, you have to remember the stridor lethargy is started. So this is urgent referral is required for this one. That is for the severe, very severe pneumonia. And for the severe pneumonia, one dose, the first dose of the injectable chloramphenicol we are going to administer. Then we are going to refer. For the pneumonia, the oral amoxicillin at the home is the enough. Okay. So I hope it is clear to every one of you. This chart is a 5-star chart and important for the exam. Please do remember. Okay, yes sir. The next thing is here. The fast breathing criteria also you have to remember. Okay, the question will strike from here. Okay, so here it comes to the next question. Already done question. So concept also in a recent rapid revision session only I covered this one. So please don't make any mistake in this question. What is the mid upper arm circumference cutoff for the diagnosis of the sham? Yes. Two times or one times already I have discussed this question previously in the YouTube only, in the free of cost only we have done this one. Okay, yes. So that is in the less than 10.5 centimeters the cutoff for the our SAM. If the mid upper arm circumference, that is the age independent circumference of the our anthropometric measurement, so that is the mid upper arm circumference. If it is less than 11.5 centimeter, so this is we call this is the category of the severe acute malnutrition. Okay, so in the SAM category we will be having this one. Remember, this is the screenshot what we are going to take now, and you are going to revise. Okay, so yes, so this is a 5-star table for your exam, and from here you will definitely expect one question. Okay, so that is the severe acute malnutrition, which is categorized for the 6 months to a 59 months age group child, where the weight for the height according to Z score is less than -3 standard deviation, and mid upper arm circumference is less than 11.5 centimeter, and the bilateral pitting edema, there is a nutritional edema, what we can say, this is present especially on the both the feet on the legs. So this is the criteria of the SAM, that is the severe acute malnutrition. So please do keep in your mind, this is important for the exams, right? Yes, is that clear to every one of you? Yes. So one more time, just given the revision. Okay. So now here you see this in this particular concept. So this is in the very important concept what I am going to explain to you. So that is on the protein and energy malnutrition. So that is on the PEM. This is one of the examiner favorite concept. So from here you can expect one question in the exam. So you can see this particular boy number A. He is a boy number A. Okay, so he is the case of the Kwashiorkor. He is the case of the Kwashiorkor. What is the problem in the Kwashiorkor? So my option is a severe deficiency of the protein, and option B is severe deficiency of the energy. So choose the answer. Option A in this particular child number A, whether the protein deficiency or whether the protein deficiency or calorie deficiency. Very nice. So the Kwashiorkor means there is the deficiency of the protein. Okay, so here the protein is going to decrease, right? So protein is going to decrease means, so there is the severe deficiency of the protein means we can say decreased albumin. Decreased albumin we can say, yes sir. So you know albumin is the main and very important thing which will maintain the plasma oncotic pressure. Where there is the decreased albumin means there is nothing is there inside the blood to pull the fluid that is which is outside the blood vessel to inside the blood vessel, right? So what is the normal function of our albumin? So that will maintain the plasma oncotic pressure. So how? Remember, this is the blood vessel which we have, and this is the fluid which is there, and the plasma. Inside this plasma we have the albumin, that is the plasma protein. Okay, so this plasma protein very much important because it will maintain the plasma oncotic pressure. The fluid which is there outside the blood vessel, this particular albumin will suck this particular fluid inside, and it will prevent the leakage of the fluid from inside to outside the blood vessel. Okay, so it will not allow the fluid to go out of the blood vessel, right? Yes sir. So here the albumin is not there. The albumin is not there means the fluid will leak outside and the outside fluid will not come inside. Okay, so which means to accumulation of the fluid in the interstitial space. So accumulation of the fluid in the interstitial space, what I can call that one? So I can call that one as in the edema. What is that one? That is the edema. Sir, what is edema? Edema is in the accumulation of the fluid in the interstitial space. If this edema happens to the entire body, so I can call that one as the anasarca. So what is the anasarca? Anasarca is the edema of the entire body. We can call that as in the anasarca. So mainly in this particular Kwashiorkor, so there is the protein deficiency. Means albumin is also in a kind of the protein. Yes sir. So albumin is also got deficient here. Means the edema will happens. So the facial edema will happens, and the edema to the feet is going to happen. Okay. Yes sir. So here the facial edema is happened means the face looks like a moon here. Okay, so the question will come, where we are going to get the moon shaped face? Yes, the moon shaped face we are going to get in the situation called as the Kwashiorkor. And in the medical surgical nursing we studied in the Cushing syndrome. Yes, there also we are going to get the moon shaped face. So and here also we are going to get the moon shaped face. Okay, in a protein energy malnutrition, where means that is in the Kwashiorkor. Okay, yes sir. So protein is got deficient means, so the skin keratin also may got deficient. So all the skin will start dry and it will start to scale and it will start to come out. That is in the peeling of the skin will happen. So we will call that one as in the dermatosis. Okay, so that is the very important. So that is also is going to happen. And along with that one, the albumin is deficient and the free fatty acids will increase and the demand will increase. So the hepatomegaly will also going to happen. So the liver is also going to big here. Okay, and along with that one, the hair is also requiring the protein. So there is in the no protein means the hair become different color here. So that is the a flag here we are sign we are going to get, means the half of the color will be different and another half of the color will be different. So this is called as the flag here sign. Okay, so that is also going to get in the Kwashiorkor. But what happens in the Marasmus? So Marasmus mainly there is in the Marasmus mainly there is in the deficiency of the energy. So or there is in the deficiency of the calorie. Okay, so when there is in the insufficient energy or insufficient calorie, that time our body will try to break all the fat which is there already. It will break the fat, it will break the protein, okay, and it will utilize for its regular things. So this happens when the like child are not takes the insufficient nutrition. So that time this protein energy malnutrition will happen. So when there is in the deficiency of the energy, all the body muscles, fat, protein is going to break, and child is completely thin, lean. Okay, you can see the all the ribs of the child very easily. Without x-ray you can see the bones. Okay, yes. So because there is no any muscle mass, there is no any fat, there is no any protein, there is no any building block of the body. So there is in the body is completely weak and the thin. So that is thin and weak body you are going to get in the Marasmus. Okay, and the edematous body will be seen in the Kwashiorkor. This is the very important you are going to understand here. Okay, and here the this particular fat of the our cheekbone is going to loss, and this will go inside, and the fat of the our orbit, that's the eye orbit, is going to loss. The eyes also will go inside, and the face looks like a monkey. So the monkey like face we are going to get in our Marasmus. Okay, in a Kwashiorkor moon shaped face, and in the this one very important Marasmus, the monkey like face we are going to get. So this is very important for the exam, please do keep in our mind. Okay, so here is the quick revision points on the Kwashiorkor and Marasmus. First I will deal the things which is related to the Kwashiorkor, then we will come to the Marasmus. Okay, yes sir. So understand now, as I already told you, that is in the Kwashiorkor, this happens mainly due to the deficiency of the severe deficiency of the protein. Okay, so there is in the adequate or the near adequate calories are there, but there is in the deficiency is there in the protein, that is not normal deficiency, there is a severe deficiency of the protein is there. Okay, so how body will appear here? So that I told, due to the loss of the albumin, there is no protein is there inside to maintain the plasma oncotic pressure, because albumin is the protein which maintains the plasma oncotic pressure. If no albumin, no protein means no albumin, no albumin means no plasma oncotic pressure. The fluid will leak out of the blood vessel into the interstitial space. The accumulation of the fluid in the interstitial space we will call that one as the edema. Okay, so entire body will be the edematous, and the face also edematous, which looks like a moon. The moon shape face will be there, and the belly will be swollen, so due to the ascites. Okay, yes sir. Next comes to the edema. Edema is present in this one. Okay, especially in the legs and face, and most importantly muscle wasting. So may be present, but it is masked by the edema. Okay, so the hair changes, this is important. Where in the hair changes you are going to get the flag sign. So that is very important. Hair are completely thin, and so discolored hair. So this half of the hair will be different color, then another half of the hair will be different color due to the loss of the protein. So that is the flag sign we are going to get in the our Kwashiorkor. Okay, very important. Then the skin changes. There is no keratin protein in the skin, so there is in the dermatosis will happen. That is the flaky paint dermatosis we will say, because here there is in the like peeling of the skin will happen. The natural skin and the peeled skin, the natural skin, peeled skin. So it will also will looks like a different color. Okay, so that is in the flaky paint means it will be like the flaky paint means, you know, after some years the paint will go out of the wall, like the skin will peel out. Okay, so skin will go out of the our body. So that is what you can say of flaky paint like dermatosis. So this is very important. The cracked and peeling skin will be there. So this one will be seen in the severe protein deficiency, that is on the our Kwashiorkor. Okay, so face appearance, moon shaped face due to the edema, and hepatomegaly will be present, and the appetite will be usually lost appetite or the poor appetite will be there, and activity will be completely lethargic and irritable. Okay, yes sir. So next which we have here is, that is our Marasmus. So what happens in the Marasmus, sir? There is in the severe deficiency of the energy or the calorie will be there. Okay, so the no energy intake means our body will start to destroy our own fat which is stored in the body. Okay, so that is destroyed means like all the muscle will get start to waste, means the muscle is going to lose its strength and all its protein, fat, everything is, it is going to lose. And emaciated looks will be there, means very thin, lean, and the like all the bones are clearly visible. You take out the shirt, inside the skeletal system only will see. Okay, yes, so that kind of the things will be there. Okay, and skin bones are easily appearing. And absent, sir, what absent? Edema is absent, because here we not having the protein deficiency. Okay, so edema is absent in the marasmus. In the marasmus there is no edema. Okay, so but the severe muscle wasting will be there. Thin dry hair will be there, but there is no any hairs like flag signs. Dry and wrinkled skin will be there, but there is no flaky pain dermatitis. Flaky pain dermatosis will be seen in a case of the our Kwashiorkor. In the marasmus, just a dry and wrinkled skin will be there, and monkey like face will be there, because eyes are sunken and cheeks are loss of its fat, so it looks like a monkey face. So the monkey like face will be there in the our marasmus. Okay, and remember there is no hepatomegaly in the marasmus, but in the Kwashiorkor hepatomegaly will be there. But appetite and activity in the our very important marasmus, usually good appetite and the complete alert but weak. So why? Because sufficient calories not getting but alert. Okay, so usually good appetite will be there, or the more hungry will be there. The child is more hungry here because he require the energy, so he need to eat more. So that is the usually good appetite will be there in the most important our marasmus. So this is the difference between the Kwashiorkor and marasmus. This is very important for your exam. So now let's begin the some very important one liners for your exam. Okay, so now tell me the answers. The first question. Okay, so let me ask the question directly to you only. I want answer from everybody of you in the comment box. Flaky paint dermatosis is a classical sign seen in. A flaky paint dermatosis is the classical sign seen in which condition? Flaky paint dermatosis. Yes. Tell me the answer. Very nice. So that is in the case of the Kwashiorkor. The flag hair sign will be seen in which condition? Flag hair sign. Kwashiorkor. Monkey-like face, wasted muscles, only skeletal system, active and alert, good appetite will be seen in which condition? Very nice. So that is in the marasmus. Okay, so deficiency of the calories mainly in marasmus. So deficiency of the protein mainly in the Kwashiorkor. Okay, yes. Where will be the boggy pant appearance? Boggy pant appearance will be in the marasmus. Sir, why? You know the baggy pant, there is in the loss of the muscles mainly from the buttock of the buttock muscles is going to loss mainly. So in the marasmus, right? So whenever the child will wear the pant, it will come down and the half will be like it is looks like a boggy pant. You know the boggy pant where the japes will come completely down. All right. Yes. So the boggy pant appearance will be there in the marasmus due to the loss of the or due to the wasting of the buttock muscles. Okay. Yes. So that's very important. Boggy pant appearance will be there in the marasmus. So add on this very important point also. Right. Yes, sir. Right. Okay, so now it comes to the very important discussion here. There is on the treatment of the severe acute malnutrition management. So this is in the management of the SAM or the malnutrition management. Here I am going to explain 4 to 5 very important words that is most important for your exam, and in the exam you are going to get these questions only. Okay, yes, sir. Sir, how we are going to manage the SAM? So last 6 months, 1 year, 2 year, there is no sufficient fluid, there is no sufficient food, there is no sufficient protein, there is no sufficient energy. Suddenly you are giving everything means our body will not tolerate. So we have to give that one by step wise. then only it will start to adapt, and whatever you are giving the intervention, that will be effective. So there is in the severe calorie and protein deficiency, I will give the 1 kg of the protein and 1 kg of the calorie now, and it will be recovering. No, it will not recover like that. So whatever you are giving, the body should adapt to that, and then only it will be getting recovery, right? That is the reason here we have the 4 phases in the management of the malnutrition. So first phase is the stabilization phase. This is for the 1 to 2 days when we will take handover of the child. Okay, yes, sir. So that is in this particular stabilization phase, only we will focus on the any imbalances there, so that one we are making to comes to balance. So there is any severe dehydration is there, fluid balance we will make. Any infection is there, we will treat that one and we will bring back to the normal. Hypothermia is there, we will keep the warm and we will keep the normal. Hypoglycemia is there, we will make into the euglycemia, that is blood glucose level, we will bring into the normal. And here we are going to start with the F75 diet. Sir, what is the F75 diet? The 75 kilocalorie of the 75 kilocalorie of the energy will be there. There is a calorie will be there, and 0.9 gram of the protein will be there. So that is in the F75 food. Okay, in the F75, 75 kilocalorie of energy will be there, and the 0.9 gram of the protein will be there. The protein will be low here. Okay, so this is low protein we have. And remember, there should not be any provision for the iron in the stabilization phase. So the question will comes not from this, not from this. The question will comes from this. So that is no iron in the stabilization phase. The golden point. Sir, what happens if I give iron in this particular stabilization? The baby is not stable here. So the child is not stable here. That is the infectious, dehydrated, hypothermic, hypoglycemic, the instability, imbalance is there in the body. That time, if you are giving the iron, it will form the free radicals and it will start to damage the internal organs. So that is the reason in the stabilization phase, we must and should avoid the iron. Very important. Okay, yes. And which food we are giving in the stabilization phase? Remember, this is the question, that is the F75 diet we are giving. In the F75 diet, what is the calorie level? That is the 75 kilocalorie of the calorie will be there, energy will be there. So it is having the high protein or low protein, that is having the low protein, that is only 0.9 gram of the protein is there. Important. Okay, so here we are trying to just stabilize the child. And remember the golden word, no iron in the stabilization phase. Okay, yes, sir. This is for the 1 to 2 days duration, and after this one we have the transition phase. We are going to shift from the F75 to F100 food. So that is transition phase after 2 days, that is 2 to 3 days. In the transition phase also we are not going to provide the iron. Iron will be provided in the rehabilitation phase. Okay, so I will teach that one. In the transition phase, what we are doing? So we are converting from F75, that is the 0.9 gram of the protein what we have, from there into the 2.9 gram of the protein we are shifting. Okay, so yes, in the transition phase means from one form to the another form we are shifting. So that is the transition phase. It is there for the duration of the 2 to 3 days. And here most important thing is this one. So we are shifting from the F75 to F100. Okay, this is very important. You are going to keep in our mind. That is the higher energy and higher protein. So that is the 2.9 gram of the protein is there in the F100 food. Okay, so that is in the F100. So there is in the 100 kilocalorie of the calories there. So that is the high energy, and the protein also 2.9 grams. So this is what it is there in the F100 food. Okay, yes. So next which we have is the rehabilitation phase. So rehabilitation phase is no any time bound. So this is ongoing phase. So we will start to rehabilitate the child. So very important. So here we are going to keep on the full F100. So that is in the continuously F100 food. That is the 100 kilocalorie and the 2.9 gram of the protein wala food we are going to do, or else rough feeding. So that is the ready to use therapeutic food we have. So that is the rough feeding we are going to provide. Okay, and here we are going to start the play therapy and sensory stimulation will start, and iron supplementation starts here. Okay, yes, this is the golden point. In which phase of the management of the severe acute malnutrition we will give the iron? So we will give the iron in the rehabilitation phase, not in the transition, not in the our most important first stage. So that is in the stabilization stage and the transition stage. We are not going to provide the iron. Iron will be supplemented in the our most important rehabilitation phase. Okay. And the next which we have is the discharge and follow-up phase. So the criteria of the discharge is very important here. So in the SAM baby, where the weight for height was less than 3 standard deviation, if it is improving and the baby was not having the sufficient food, so that is coming to the normal, the child is active and eating the food, and there is no edema from the last 2 weeks. Okay, so in this particular situation, we can discharge the child and we can follow up on the regular basis. Okay, so discharge criteria should be met before discharging the child. Okay, so what is the discharge criteria here? The weight for height is more than or equal to 2 standard deviation. No edema for the last 2 weeks, more than or equal to -2 standard deviation. Remember, no edema for the last 2 weeks, and child is completely active and eating, and he can go to the home. So this is a very, very important thing, the discharge criteria for the severe acute malnutrition child. So that I hope it is very much clear to everyone. Okay, yes, the next question is this one. Again, very, very, very important question. I'm going to provide one more table here for the quick revision. So that is going to cover your 100% of the important syllabus before your Norcet prelims. Okay, for the Norcet means we will go to such an advanced level, you will definitely get the rank. Okay, so it will float in the top 100 only. It is promised from my side. I will give my best. You also be ready to give your best. Okay, so then only when the two hands will comes together, so it will create a clap, right? Yes, the clapping is not possible only from one hand. It requires the two hands. So this hand is very tight from my side and very perfect from my side. If you are ready, we will make it happen. Okay, yes. Which of the following is true about physiological jaundice in the newborn? Question is about the physiological jaundice. Already you studied this one, the difference between the physiological and pathological jaundice. Okay, so already the Raghavs are perfectly covered in the A1 plan. Okay, yes. Which of the following is true about the physiological and pathological jaundice? It is not a very simple thing. So you are going to quickly revise the entire thing from this one. So that is very important for your exam here. Okay. So the option is appears within first 12 hours of the life. Is this physiological jaundice appears within 12 hours of the life? No. If it is happening within 24 hours, so we call that one as in the pathological jaundice. It is the patho, not a physiological. And which is called by the biliary atresia. There is in the problem is there in the anatomy and physiology, like anatomical problem, or there is in the any pathology is there. So because of that one, the jaundice is happening means again that is in the pathological jaundice. Okay. Then option C is that it peaks between the 3 to 5 days of the life. Is this peaks between the 3 to 5 days of the life? And option D is it requires the immediate exchange transfusion. But exchange transfusion is required for the pathological, not for the physiological. Okay, so this is only thing which is the physiological here. So this is the correct answer. Option C, peaks between the 3 to 5 days of the life. Okay, even you know we don't know the correct answer, but if you are eliminating with the strategy, so that is going to help. Okay, so yes, there is in the rise in the bilirubin in the first 24 hours. You know the very simple definition, that is the pathological jaundice, and something is problem that is not a physiological, that is the pathological. The biliary atresia is there. Is this a physiological? No, sir. This is the pathological. So that is the pathological. And exchange blood transfusion is required means it is not a normal. This is the pathological. So eliminate the 3 pathological things and remaining one is the physiological that peaks between the 3 to 5 days of the life. This is how you are going to take a chance. And you know only 2. So you know, but suppose you consider I am teaching you the skill to solve the MCQ here. You know these 2 are not correct answer and you eliminated these 2. And you have the doubt in these 2. Sir, whether I need to attend this one or I should not attend this one. Yes, you tell me the answer. You don't know the 2 options and you know these 2 options are not correct answer. And you are having the confusion in these 2. So whether you are going to attend the question or you are not going to attend the question. that is depends on your calculated risk. So consider for suppose. So this is in the a section which is A section. From here to here we are having the question number 1, 2, 3, 4, 5, 6, 7, 8 and 20 questions are there. So till now you attended only 15 question or the 14 question. So you are going to take a risk like in a 50-50 questions, attend the 2 questions. Okay, like this question, the 2 questions you attend, not more than that. Okay, sir, already here you attended the 18 question in this particular section. Okay, so that is very perfectly you attended, and the 2 questions are remaining. In that one I have the doubt, so don't attend because here the accuracy matters. Getting the point? Yes. So you have attended the less questions, so then you attend, take a risk for the 2 very important questions, and if you are attended the 18 questions very perfectly, so you have the only doubts in the 2 questions, so that you leave. Okay, yes. So here the correct answer for this question goes to the option C. It peaks between the 3 to 5 days of the lives. So that is very perfectly you all given the correct answer. So I hope it is very clear. Okay, so here is the quick revision table. This is very important for your exam. So please revise this one very perfectly after the class from the A1, A2 batches. Okay, that is very important for your exam. So here we have the physiological jaundice and the pathological jaundice. You first tell me what is the jaundice, what is the icterus? That is increased bilirubin level in the blood. We call that is the jaundice or the icterus. Okay, yes. So this jaundice in the newborns, it happens normally also, it happens abnormally also. So normally happening due to the immature liver, because the newborn means just now it's born, its liver is not fully matured. So the unconjugated bilirubin is not getting converting into the conjugated bilirubin. So it is not getting converting means the unconjugated bilirubin is rising. Okay, it is increasing. So now tell me in the physiological jaundice, the conjugated bilirubin will increases or the unconjugated bilirubin will increases? Sir, unconjugated bilirubin is going to increases. Right? So why? Because here we have the liver. So this liver is responsible for converting the unconjugated bilirubin to the conjugated bilirubin. In the newborn, this liver is immature, and the UDPGT enzyme that is responsible for the conversion of the unconjugated to the conjugated bilirubin, that is not there sufficiently. So it is not getting converting means there is no conjugated bilirubin, the unconjugated bilirubin is increasing. So in the physiological jaundice, unconjugated bilirubin mainly it will increase because of the immature liver. Okay, yes sir. So very important, please do keep in your mind. And you consider in the biliary atresia, what happens? So biliary atresia means there is a problem in the biliary system, there is in the abnormally biliary system is closed. So you know, after converting this unconjugated bilirubin to the conjugated bilirubin, it will comes into the biliary system. Okay, so now here the atresia is there in the biliary system. Okay, this is the liver, and here we have, you know about biliary system, I think so. Okay, so this is the right hepatic duct, left hepatic duct is there, and here we have the cystic duct, and this is our common bile duct. So now this common bile duct is abnormally congenitally closed here. So this is the biliary atresia. Okay, yes sir. So there is no problem in the liver. Liver is converting the unconjugated into the conjugated. Right? Yes sir. But this conjugated bilirubin, it should excrete from here. It is not get excreting from here because it is blocked here. So in the biliary atresia, which kind of the bilirubin is going to increase? The conjugated bilirubin is going to increase in the biliary atresia. In the immature liver, in the physiological jaundice, our unconjugated bilirubin is going to increase. Getting the point? Because the liver is immature, because the just now only baby born. So in the newborn babies, liver is immature and the liver enzymes are insufficient. So unconjugated bilirubin will be raised in the blood. And the biliary atresia, so there is mature liver is there. So UDPGT is converting the unconjugated into the conjugated. But this conjugated is not going out because here our common bile duct is got blocked. That is congenitally biliary atresia is there. So here in the very important conjugated bilirubin will going to rise. I hope it is very much clear. Yes. So in the physiological jaundice and the pathological jaundice, the biliary atresia is the part of the pathological jaundice, and the immature liver is a part of the physiological jaundice. Okay, remember. So most importantly, Norcet is going to be a game changer here. So physiological jaundice means it happens after the 24 hours of the birth. It will not happen within 24 hours. It will happen after the 24. If it is happening within 24 hours, it means it happened in the intrauterine life only. So that is due to the RH incompatibility or the ABO incompatibility or any other G6PD deficiency in the newborn. So because of that one, sorry, because of that one, there is the very important pathological jaundice will happen because it is bilirubin is rising within 24 hours means, so the problem is started in the intrauterine life only. Getting the point? So within first 24 hours the bilirubin is raised means that is the pathological jaundice, and after 24 hours bilirubin raised means that is the physiological jaundice. Okay, peak bilirubin level 3 to 5 days. So here the peak bilirubin level will goes to more than 12 milligram per deciliter in the term and more than 15 milligram per deciliter in the preterm. At any time it may get peak. Okay, so this is getting peak in the 3 to 5 days. Okay, and remember the very important thing, that is rate of the rise of the bilirubin for 1 day. In the physiological, the rise of the bilirubin will not cross more than 5 mg. So this is less than 5 mg milligram per deciliter per day. Okay, so but in the pathological jaundice it will increase more than 5 milligram per day. Okay, the increased bilirubin is there more than 5 milligram per deciliter per day in the pathological, less than 5 in the physiological. And the duration of the jaundice, so the physiological will usually resolve within 7 days in the term and within 14 days in the preterm, and the pathological which will persist behind the 7 days in the term and it will be present even after 14 days in the preterm. And most importantly here, indirect bilirubin or the unconjugated bilirubin is going to increase. So here mostly unconjugated, but conjugated also going to increase. Getting the point? So unconjugated will increase due to the hemolysis and conjugated will increase due to the biliary atresia. Getting the point? Yes, sir. The next is appearance of the body. So this is generally healthy and feeding well. The baby will take the feeding well and it may appear sick, poor and lethargic. And the most important cause for the physiologic is immature liver enzymes and immature liver activity, especially UDPGT or the UGT enzyme, what we can say. And here the cause of the pathological jaundice is the excessive hemolysis, where the blood will break more, there the bilirubin will be high. Okay, and the sepsis will be there, G6PD deficiency will be there, ABO incompatibility and RH incompatibility. Sir, we have these many causes. Among these all, which one is the most common cause, sir? So RH incompatibility is the most common cause. So please do remember. Okay, this RH incompatibility is the most common cause of pathological jaundice. Okay, so this is the most common cause of the pathological jaundice. So I hope it is very much clear to you, right? Yes. So next which we have is, that is our Kramer's rule in the jaundice. So you see the our diagram is there. Yes, very important diagram. So it is not a good diagram, but the concept behind this diagram is very good and very easy. Try to understand. So here, based on the distribution of the discoloration of our body, so we are going to determine the amount of the bilirubin. So that is a rule called as the Kramer's rule. This rule is called as the Kramer's rule. So in bilirubin is accumulating means our body will get discolored into which color? So that is the yellowish discoloration will happen. Okay. So here the yellow discoloration of our face and the neck happen. So the face and neck is got yellowish discoloration means how much bilirubin is raised? So 5 milligram per deciliter of the bilirubin is raised in the blood. Okay. Yes. So now you consider, I will take a little bit dark yellow. So that is our upper chest and upper abdomen. So that is the chest plus upper abdomen. This one is got yellowish discoloration. So there is the 10 mg per deciliter of the bilirubin is increased. So here the lower abdomen and the upper thigh. So lower abdomen and upper thigh. So here there is in the increased, sorry, discoloration is happening here. So that is in the upper thigh and the lower abdomen. So we can say bilirubin is 12 milligram per deciliter. Okay, yes, that is the lower abdomen and the upper thigh, right? Yes. So in case this particular lower leg, I will take the another color, black. So you take this one. Okay, so this particular lower portion of the leg, right, and our arm, this is involved. So that is the lower leg and arm is involved. That is indicating the 15 milligram per deciliter of the bilirubin is increased. Okay, so there is lower leg and arm involved means 15 milligram per deciliter of the bilirubin is increased. If in case the most dangerous, that is the foot is involved and our palm is involved. So foot and palm both involved. So that is in the sole and palm both involved means it is crossed the 18 to 20 milligram per deciliter. This is the very dangerous, and please do remember the Kramer's rule, important for the exam. This Kramer's rule is already striked in the Norcet 4 or 5 questions. So from there, this is very important for the exam. Please do keep in mind. Okay, yes, they can ask you the question. The yellowish discoloration of the only neck and face. What is the expected bilirubin level in the body? So that is the 5 milligram per deciliter. Upper, so chest and the upper abdomen, that is the 10 milligram per deciliter. Okay, lower abdomen and the thigh, so that is the 12 milligram per deciliter, and lower leg and the arm, that is the 15 milligram per deciliter. Okay, and the very important palm and sole, that is the 18 to 20 milligram per deciliter. This is very important and very important for the exam. Please do remember. Okay, the next question is here. Chalo, let's try to give the best answer. What is the age or the first dose of the pentavalent vaccine? That is the 5 vaccines together we made as the one vaccine, that is the pentavalent vaccine, is administered under the NIS, that is the National Immunization Schedule. Under the NIS, under the National Immunization Schedule, so when we are going to administer under the National Immunization Schedule, when we are going to administer the pentavalent vaccine, at what age is the question. So option is at the birth. No, at the birth we are going to provide only 3 vaccines. One is BCG, another one is which one? Yes, the next one is which one? Along with the BCG, which one we are giving orally? At birth, vaccine which is given orally. Yes, that is the oral polio vaccine. And one more, which is given by the intramuscular, which is given intramuscular at birth. At birth vaccine which is given intramuscular. Yes, that is the our hepatitis B. Okay, that is the hepatitis B. Right? Yes. So one is given intradermal, that is the BCG, intradermal, and one is given orally, that is the oral polio vaccine, and another one is given, that is by the intramuscular route, that is the hepatitis B vaccine. Okay, yes. So BCG, OPV, hepatitis B is given at the birth, and pentavalent we are not giving at the birth. I am eliminating option A. Right? Yes. Next, which we have is the 9, 16, and 12 months, and 5 to 6 years. The question is first dose of the pentavalent. So the pentavalent first dose we will not wait until the 9, 16 to 12 months. Sorry, 16 to 24 months. So we are not waiting until this month. So we are not waiting until the years also here. Just we will give the first dose of the pentavalent. Yes, absolutely. In the 6 week, 10 week, and the most important one. Let me make it proper. Okay, yes. So the 6 week, 10 week, and the 14 week is the first dose of the pentavalent vaccine we are giving. And now you tell me, the pentavalent vaccine is containing a protection against how many diseases? The word itself, it is saying that is the penta in the sense the 5. Okay, it will protect against the 5 conditions. What are the 5 conditions? Diphtheria, pertussis, tetanus, hepatitis B, and Haemophilus influenza type B. Okay, so these are the 5 vaccines combined together. We made a one vaccine, that is the pentavalent vaccine. Okay, yes sir. So this pentavalent is protecting against the DPT and hepatitis B plus Haemophilus influenza type B. So there is the diphtheria, pertussis, and tetanus, hepatitis B, and Haemophilus influenza B. So in the pertussis, we have the 2 types of the pertussis. One is acellular pertussis and another one is the whole cellular pertussis. Sir, in the penta, which one we have, sir? Acellular pertussis or the whole cell pertussis, sir? We have the whole cell pertussis. Okay, so remember, as compared to the acellular pertussis, whole cellular pertussis vaccine is having the more side effect, and this pertussis is having the dangerous side effect, that is the inconsolable cry. You will ask the baby to get silent, it will cry loud. So that is the you are unable to console and even you are unable to convince the baby. So that kind of the heavy, uncontrolled, excessive cry will be there. And there is a neurological deficit, sometimes seizures, and the paralysis also may happen. Mainly the seizures. Okay, so that is by the whole cellular pertussis. But still, this vaccine only we have in the our DPT. Okay, so in the DPT we have the our whole cell pertussis only, not a acellular pertussis. Very important, please do keep in our mind. Okay, if the question is coming in the DPT hub, so that is pertussis we have. In the pertussis, whether acellular is present or the whole cell is present, so our answer should be whole cell is present. I hope it is clear. Yes sir. So now tell me, what is the route of administration of the pentavalent vaccine? What is the route of administration of the pentavalent vaccine? Yes, intramuscular. Very nice. So that is the intramuscular is the route of administration of the penta. So what is the site? What is the site? Right upper arm, or the right side thigh, or the left side thigh? Yes, we will discuss that one here in detail in perfect. All the vaccines that is much necessary for the exam. Quickly revising and very important for the exam, please do keep in our mind. Okay, at the birth I told we are going to provide the 3 vaccines, that is the BCG, Bacillus calmette urine. At birth I am giving maximum at what time I can give, up to 1 year I can give, not more than that. Okay, so if I am giving in a less than 1 month child, so that is from the 1 month, sorry, less than 1 month means the dose will be 0.05 ml, not 0.5 ml. So this is the 0.05 ml. Remember, the first option only will get 0.5. That you will choose, and that is wrong. Don't choose. In the less than 1 month baby, the dose of the BCG is not 0.5. The dose of the BCG in less than 1 month is 0.05 ml. Remember. Okay. Yes. So this is intradermal route I am giving. Okay. So if more than 1 month baby is there, more than 1 month up to the 1 year, that is 0.1 ml intradermal. Okay. So not 0.5 again. Here the 0.1 ml intradermal we are giving. Very simple. So this is given up to the 1 year. Less than 1 month 0.05 ml. More than 1 year, sorry, less than 1 month, that is the 0.05 ml. More than 1 month up to the 1 year, that is 0.1 ml. So I hope it is clear. Yes. So 0.1 ml. So that is if you are giving this one within 1 month, that is a 0.05 ml. So I hope it is very much clear. And sir, where it is given, sir? This is given in the intradermal left upper arm. Okay. So there is one question related to this one. So I will ask one question to you. So try to respond to that one. In a recent INCAT exam, so there is a question on this one. So there is a mother will comes to the vaccination clinic after the BCG vaccine. That mother is telling there is no formation of the what we can say the scar is not formed. So even after the BCG vaccine, so here there is in the mark will form. Okay, so after the vesical pustule, so there is in the ulceration will happens, and that will convert into the a permanent mark of the BCG vaccine here. Okay, so now mother is telling there is no mark. So in the options there is an ask the mother, we will repeat the BCG vaccine And in the option B, it is the normal, no need to worry. And option C, this will happens in the babies and we need to just counsel, there is no need of the BCG vaccine, and all the above. What is the correct answer? Option C is the correct answer here. Okay, so this will happens even we will give the a BCG vaccine, sometime there is no any formation of the mark, so there is that time no need to repeat the BCG vaccine, just we have to counsel this is normal, it happens in the child, no need of the second dose. So we are going to explain like this. Okay, so that's very important. Okay, don't repeat the BCG vaccine again. Okay, yes, so this is very important for the exam. Next comes to the our hepatitis B. So this question is very important. The birth dose of the hepatitis B should be given within how many hours? The maximum time duration of administering the hepatitis B. Yes, we must and should give this is within 24 hours. If you are not giving within 24 hours, there is no use of administration of this hepatitis B vaccine only. Okay, so first dose must be and should be given within 24 hours. That's very important. So how we are going to give, sir? Intramuscular. What is the dose, sir? 0.5 ml. Sir, where we are going to give, sir? Left mid thigh. That is the anterolateral aspect of the mid thigh. In the vastus lateralis muscle. Vastus lateralis muscle. Anterolateral aspect of the mid thigh. Left side. I am going to give the birth dose of the hepatitis B vaccine. Okay, yes, sir. Next is the OPV. That is the oral polio vaccine, 0 dose. 0 dose means this is birth dose. Okay, so next we will get the primary doses. That is the first dose, second dose, third dose. Those are the primary doses. And we have the OPV 0 dose when we are going to give. So OPV 0 dose we are giving at the birth within 15 days of the birth. That is the oral route. The 2 drops orally we are going to give the OPV vaccine. Okay, yes, the question will come like this. How, sir? The birth vaccine which is given by the intradermal route, that is only one vaccine. We have intradermal route at the birth, that is the BCG. A birth vaccine that is given by the intramuscular route, that is the hepatitis B by the intramuscular route, and the birth vaccine which is given by the oral route, that is the oral polio vaccine. Okay, yes, sir. So dose of the BCG more than 1 month up to the 1 year, 0.1 ml intradermal. Less than 1 month, that is 0.05 ml intradermal. That is to the left upper arm. So which side you are giving the BCG? Same side leg only you give the hepatitis B. So that is by intramuscular. Okay. So within 24 hours we are going to provide the hepatitis B. So that is by the intramuscular route, the left mid thigh. Okay, that's the anterolateral aspect of the left thigh. So this is very important for the exam. Please do keep in mind. Okay, yes, sir. The next question is, the next concept is this one. That is the pentavalent, what we have discussed now. Pentavalent is protecting against the 5 diseases. That's the pentavalent, the diphtheria, pertussis, tetanus. And in this one, the pertussis which we have is the whole cell pertussis. And that pertussis is the responsible for the severe dangerous side effect, that is the neurological deficit and severe and inconsolable cry. Okay, so that is very important. Schedule 6 week, 10 week, 14 week. So there is in the 4-week gap between the each dose. That is the very important. So pentavalent first dose to be provided in the 6 week, then 4-week gap, second dose at the 10 week, 4-week gap, third dose at the 14 week. So these are the 3 doses of the penta vaccine we are providing. Okay, so dose is 0.5 ml intramuscular. This is also left side of the mid thigh only. Very important. That is the anterolateral aspect of the mid thigh. Okay, yes, sir. So during this time, we are going to provide the very important one more vaccine by the intramuscular route. So that is the PCV vaccine. Okay, so at the 6, 10, 14 week, we are providing the pentavalent, that is by the IM route. So here to the left thigh. So we are already given at the left thigh, means the one more vaccine which is given at the same time we should not give at the left thigh. So that is the PCV vaccine, that is the pneumococcal conjugated vaccine which is given against the pneumonia. In order to prevent the severe pneumonia, we are providing the PCV vaccine. So this is given only at the 6 week and the 14 week, not given at the 10 week. Remember, the PCV and IPV is not given at the 10 week. It is given 6 week and 14 week. Okay. So at the 6 week, Penta I given I am at the left thigh, means at the 6th week, the pneumococcal also I am going to provide at the intramuscular, so same dose 0.5 ml, but I can't give in the left thigh, so I will give in the right mid thigh. Are you getting the concept? Yes. So very importantly, a pentavalent 0.5 ml at the 6th week, 0.5 ml I am left mid thigh, and the pentavalent, that is the pneumococcal conjugated vaccine, so that is the 6 week 0.5 ml right mid thigh. So very simple question is the penta given in the IM, that is the left mid thigh, and the PCV given IM in the right mid thigh. So the very important question you are going to keep in your mind. Okay? Yes. So next very important, we are going to provide the 6 week, 10 week, 14 week is OPV first dose, second dose, third dose. Sir, why you mentioned here the first dose, sir, in the birth dose only given? But birth dose is the OPV 0 I told. Okay, so not a very important point. This is the 0 dose or the birth dose. This is the 0 dose or the birth dose. Here also we are providing the 2 drops. This is not a OPV 1. This is the OPV 0 or the OPV first dose. Sorry, OPV, what we can say, birth dose. Okay, very important. Next we have the OPV 1. So that is given at the 6th week. And OPV 2 at the 10th week. OPV 3 at the 14th week. Okay, so 2 drops orally. So this is also very important. This is prevented against the polio infection. Okay, so next is we have the rotavirus vaccine. How we are providing the rota? Rota we are providing again orally. Sir, when we are providing same 6, 10, 14 is the time we are providing the rotavirus vaccine. Sir, what is the dose? 0. Not 0. So this is a 5 drops oral we are going to provide. The 2 things which we are providing orally, that is the OPV and rota. Okay, and rotavirus vaccine is going to provide 5 drops oral retrospective schedule. So you can remember. So sorry, respective schedule you can remember. So that is a first dose at the 6th, then second dose at the 10th, third dose at the 14th. So that is the 5 drops orally we are providing. Now my question is, there in the option there is no 5 drops. Examiner mentioned 2 ml of the rota oral, 3 ml of the rota oral, 2.5 ml of the rota oral, and 3.5 ml of the rota oral. So what is the dose you are going to choose now? This is option A, B, C, and D. What is your answer? Rotavirus, which is you are providing 5 drops. In the option in the examiner not provided the 5 drops. He given this one in the ml. So what is your answer? That is the 5 drops you can mention as an answer, or else you can mention 2.5 ml as the correct answer. Are you getting the point? Yes, sir. So that is 5 drops or the 2.5 ml. So are you getting the point? Yes, sir. So I hope it is very much clear. Next we have the fractional inactivated polio vaccine. So that is the IPV we have. So IPV I told we will not give at the 10 week. So 6 week and direct 14 week. And the PCV also 6 week, direct 14 week. We are not going to follow the 10 week in the IPV. Remember. Okay? Yes, sir. Sir, what is the dose of the IPV, sir? That is the 0.1 ml intradermal, 2 fractional doses we are giving at the right upper arm. So very important. Okay? So PCV is, I already told, the 0.5 ml IM, that is the right mid. Sir, is this IPV is live vaccine or killed vaccine, sir? This is the killed vaccine. Sir, OPV, sir. OPV is the live vaccine. This is the live vaccine. Please remember. So OPV we also called as the Sabin. So we also call the Sabin for the OPV. And for the IPV we also called as the Salk. So OPV is also called as the Sabin. And IPV we also called as the Salk. Okay, so please do keep in your mind. Okay, yes, sir. So OPV is the oral polio and IPV is the inactivated polio. So that is the killed polio vaccine. So we are giving at the fractional. Previously unfractional, that is the 0.5 ml IM we were giving. That is as per the old schedule. In the new schedule, that is in the IPV is that 0.5 ml intradermal, 2 fractional doses at the right upper arm we are going to provide. Okay, yes, sir. So I hope it is very much clear at the 6, 10 and 14 week vaccines. Now you tell me which vaccine we can't provide at the 10 week. Which 2 vaccines we are not going to give in the 10 weeks. So at the 10 week, yes, the inactivated polio vaccine will not be given at the 10 week, and the PCV also, that's against the pneumonia, what we are giving, that's the like pneumococcal conjugated vaccine. So these two vaccines are not given at the 10 weeks. So this is the question which is already asked in the exam. So please do keep in your mind, and that is important, right? Yes. So the next question is here. The vaccine which we are providing at the 9 to 12 months. But from here, 3 to 4 questions, not 1 and 2. 3 to 4, that including the prelims and mains. Don't neglect. Completely be focused. This is helpful. Okay, yes. So 9 to 12 months, we are going to provide MR1, that is the measles and rubella first vaccine. Very important. 0.5 ml, but subcutaneous. Sir, now you tell me whether the measles is the live vaccine or kill vaccine, sir. Measles is the live or killed? Yes. The measles is live vaccine. So remember, this is the live vaccine. Okay. Sir, what is the maximum age we can give the measles, sir? So we can give up to 5 years. We can give up to 5 years. If 6-year child coming, don't give the measles. There is no any sense in the giving the measles in the 6, 7 year and 8-year child. Okay, so measles we can provide up to only 5 years. So please do keep in your mind. Okay, so MR1, measles and rubella, 0.5 ml subcutaneous. Okay, so first it is given at the 9 to 12 months, and this is not only important, this is the very important multiple time asked question in the exam. Okay, yes sir. The next which we have is a question: is this measles is a powdered form or the pre-diluted form? So measles will be a powdered form. So now you tell me MR vaccine. So what is the diluent we will use for the dilution of the measles? Yes. Measles diluent. Remember, very simple. I already have told the tricks previously also to you all. So this is the M. Just push the M. Okay, I'm pushing the M, and M become W now. Okay, so we are using the water. Sir, which water, sir? We are using the distilled water. Okay, so no normal saline, no phosphate buffer. So we are using the distilled water to dilute the measles. So very important. So are you getting the point? Yes. So measles is the live vaccine given by subcutaneous route. Time is the 9 to 12 months. First dose of the measles is given. Okay. So previously we were giving the MMR. That's the measles, mumps, rubella. So now this is removed. That is the mumps is removed. Okay. So now we have the MR only. So now what we have? So we have the MR only. Okay. So to dilute this one, what we are using? So to dilute this one, we are using the most important distilled water. Getting the point? Yes, sir. The next very important thing is that's the PCV booster dose. Very important. Here we are giving the again 0.5 ml intramuscular at the right mid thigh. Getting the point? Yes. Next is JU vaccine. Remember this one point also here. So the MR subcutaneously I told. So site is the very important. That is the right upper arm is the site for the MR vaccine. Okay, and the PCV, there is the pneumococcal conjugated vaccine. So this is a booster dose 0.5 ml intramuscular again. So here the right mid thigh. So we are going to provide, or the anterolateral aspect of the right mid thigh is the very important. Next we have the JU vaccine. So Japanese encephalitis sickness we are giving the vaccine. So it's mainly in the endemic districts we are going to provide. Endemic in the sense, what's the endemic? Where the disease is constantly present in that particular area, that is called as the endemic. What is the pandemic? Sudden spread of the disease to whole worldwide, that is the pandemic. Okay, so what is the epidemic? Epidemic is the, yes, sudden burst of the diseases in a one particular geographical area, not in the whole world. In a one particular geographical area, sudden increase in the cases are called as the epidemic. What is the sporadic? Sporadic means a scattered cases. Here too, there too, there too, there too. So like a scattered cases are there. That is the sporadic. Right? So endemic means the disease is constantly present in that particular geographical area. That is the endemic. So wherever the Japanese encephalitis constantly present in the area, so that is in that particular districts, we are going to provide the JU vaccine. So that's the JU1. Okay. So here the most importantly, live vaccine we are providing means that is 0.5 ml subcutaneous we will give, and the where we are giving left upper arm we are giving. And if we are giving the killed vaccine, that is 0.5 ml, that is the intramuscular we are giving. Remember. So this is the examiner favorite point. Live JV will be given subcutaneous. Killed vaccine will be given IM. So whatever the vaccine which we are giving IM, almost all killed vaccine. Hepatitis B, giving IM, killed vaccine. And the pneumococcal conjugated vaccines, so that is the PCV. It is on the polysaccharide and again the form of the killed vaccine. Okay, and Japanese encephalitis killed, we are giving IM, again the killed vaccine. Okay, so pentavalent, all the killed vaccines. Okay, so very important. Please do keep in your mind, right? So DPT killed, hepatitis B killed, Haemophilus influenza type B, which is used in the penta, is killed. So killed vaccine only we will give the IM. Okay, so killed in the sense, remember IM. Okay, so live vaccine in the sense the subcutaneous. Okay, so very important. Live vaccine we will never give the IM. That is BCG is the live vaccine we are giving by intradermal, and measles is the live vaccine we are giving by the subcutaneous, and the Japanese encephalitis we have the live form, that is again given the subcutaneous. So some like live is never introduced in the muscles. Remember. Okay, so that's very important. Please do keep in your mind. Right. Next which we have is that is our vitamin A. Along with the measles, we are giving the first dose of the vitamin A. So that is the 1 ml, or we can say 1 lakh international units. So here the 1 ml of the syrup containing the 1 lakh international unit of the vitamin A. The first dose is 1 ml or 1 lakh international unit. Up from the second dose till the 8th dose. Total how many we will give? We will give the 9 mega doses. So that is first dose at the 9 to 12 months what we are giving in this particular time. The 1 ml we will give, that is 1 lakh international unit. That is the oral route we are providing, and remaining all the remaining 8 doses. So that is the 2 lakh international unit or the 2 ml. So we are going to provide total 9 mega doses, 17 international units. Okay, 17 lakh international unit is the total vitamin A we will give within 5 years. So first dose, second dose, and from the second dose to third dose, what is the gap? There must be a 6-month gap. Okay, so very important. Vitamin A, the first dose 1 ml is equal to 1 lakh international unit. Very important. Next which we have is the third dose of the fractional IPV. This is recently added in a intensified mission Indradhanush 5.0. So previously the third dose of the FIV, that is the fractional IPV. So FIPV we were not having previously. So this is in an intensified mission Indradhanush 5.0. This is in the update. Please do keep in your mind. Okay. So this is which vaccine third dose is introduced in the intensified mission Indradhanush 5.0. So that is the fractional IPV third dose we introduced in the our national immunization schedule at the 9 to 12 months. So that is the third dose of the fractional IPV we are giving. Okay, so that's the very important. Please do keep it. Okay, yes sir. The next which we have is vaccine which we are providing at the 16 to 24 months. Very important. The MR2 we are giving same again 0.5 ml subcutaneous right upper. Okay, and the DPT booster dose. Remember the DPT booster dose which we are providing here, the DPT booster 1 is provided in the left mid thigh. So we will study the DPT booster 2 here. So the DPT booster 2 here, this is not giving at the thigh. This is provided in the upper arm. Sir, which side upper arm, sir? Right upper arm. Okay, remember. So the 2 DPT booster we will give. DPT booster 1 and DPT booster 2. DPT booster 2 at the 5 to 6 year, we are providing in the right upper arm. Same intramuscular 0.5 ml. Because the 5 to 6 year, muscle mass is grown in the upper arm. So we can give the injection. Okay. So here it is 16 to 24 months. That is still there is no sufficient muscle mass in the our deltoid. So we will not give here. So we are going to give this one the left mid thigh. Remember the DPT booster 1.5 ml intramuscular in the left mid thigh. DPT booster 2, that is the 5 to 6 year of the life, that is right upper arm. Very important. Please do keep because next is the very important thing, that is the OPV booster 2, again oral 2 drops, and JE2 if applicable and in the pandemic routes only. So that is the same thing. Killed JV you are giving 0.5 ml intramuscular. Live JV you are giving, that is the 0.5 ml, that is subcutaneous. Very important. Next we have the vitamin A doses. So that is the second dose to the 9th dose, the 2 ml or the 2 lakh international unit every 6-month gap till the 5-year we are giving. So that's the total 9 mega doses, 17 lakh international unit we are providing. This is important and very important for the exam. Please do keep in our mind. Next comes to the our 5 to 6 years. So I told the DPT booster 0.5 ml IM, that is the right upper arm. Next 10 to 16 year, that is the TD1, tetanus and diphtheria 1. Okay, so the TD1 or the tetanus and diphtheria 1 we are giving. Remember beta, previously we used to give the TT, so that is only protecting against the tetanus. Now we are giving the TD, so this will protect against the tetanus plus diphtheria also. Okay, so 10 to 16 year age group children's, they will get one dose at the 10 year and one dose at the 16 year. So 10th and 16th year, that child will get the 2 TD doses. So that is the 0.5 ml intramuscular upper arm. So now we have the TDAP for the pregnant women. So like it is not in the national immunization schedule, but our local guidelines and the Indian guidelines is recommending that is the use of the TDAP. That is the TDAP is the tetanus, diphtheria and acellular pertussis. Okay, so acellular pertussis is giving, so it is not that is much severe side effect. Okay, whole cell pertussis is having the severe side effects, so remember. But as per the national immunization schedule, TD is only recommended. We will give the TD only. Okay, yes, at the 10th year of the life and the 16th year of the life in the children, so we are giving the TD. So that is the 0.5 ml at the upper arm. Okay, so next we have in the vaccines in the pregnant woman. This is important. TD1, not TT, TD1, that is early pregnancy, 0.5 ml intramuscular upper arm. Okay, so because pregnant woman means the more than 18 year only, all the muscle mass are very good at the right upper arm and left upper arm, so we can give in the upper arm. Okay, yes, the TD2, that is from the first week to the first dose to the second dose, the 4-week gap. The early pregnancy is recommended in the national immunization schedule, but usually in the practical situation we will give this one at the 16th week of the pregnancy. If they want single best answer, when we are going to give, there is no word called as the early pregnancy in the options. So the next best answer which we are going to choose is we will give the 16th week. Okay, at the 16th week we will give our TD first dose, and from here to here the 20 to 24 weeks. So that is in between the 20 to 24 weeks, second dose we are going to provide. Okay, so this is very important to be keeping in mind. But as per the national immunization schedule, as soon as possible in the pregnancy, that's early in the pregnancy, the first dose, and after 1 month or the 4 week, the second dose. So that is the TD second. Okay, so this is very important. 4 week after the TD1 is the TD2 dose we are giving. Sir, any change in the dose? No, there is a 0.5 ml IM upper arm same. Okay, so TD booster. So to whom we are giving the TD booster? So a first time pregnant woman, she taken the TD1, TD2, and within 3 years again she got pregnant. So for that pregnant lady, there is no need to give the TD1, TD2. If she is getting pregnant within 3 years, give TD booster only, that is enough. Getting the point? Yes, sir. If two TD doses are already given in the previous pregnancy, and she pregnant again, she conceived again within 3 years, not after 3 years. If she pregnant again after 3 years, repeat TD1, TD2 both. If she conceived or she is pregnant within 3 years, so 0.5 ml intramuscular upper arm we are going to provide the TD booster. Okay, yes, remember this is the case scenario, so they can examine the provide to you. So previous pregnancy, woman is taken the TD1 and TD2, within 3 years she got pregnant again, so current pregnancy happened again within 3 years, only TD booster we are going to provide. If in case previous pregnancy she taken the TD1, TD2, and after 3 years she got pregnant. So then TD1 and TD2 both we need to repeat. No TD taken in the previous pregnancy. So any duration no matters. We are going to provide the TD1 and TD2 in the current pregnancy. So this is a very important situation you have to keep in your mind. Okay, so next is this question. What is the main purpose of the performing the shake test on the vaccines? So this question is waiting for your answer. What is the main purpose of performing the shake test on the vaccines? So can I ask some question before moving to this particular question? Yes, so I will check how much you understood about the things what I have told till here. Okay, so leave over this question. Leave over this question. I will ask some question. Try to answer to this. DP2 booster 1 given at what site is the question. Difficult. DP2 booster 1 given at what site? Yes, to the upper extremities or lower extremities. You tell that's it. Okay, at least. Very nice. So that is DPT booster 1 is always given in the booster 1 DPT. That is most importantly, remember here what we studied in the left mid thigh. So because DPT booster 1 is given between the 16 to 24 months. Okay, so still muscle mass is not developed properly. Okay, so very important. DPT booster 2 dose is given at the which site? That is given at the 5 to 6 year of the life. So at the 5 to 6 year of the life, DPT booster 2 dose we are giving which site? That is to the upper arm, that is the right upper arm we are giving the DPT booster 2. Very nice. Okay. So now my next question is, the pregnant woman, she comes to the OPD and you are a nursing officer who posted in the vaccination clinic and you are asking the history. So when does your last pregnancy was? She told 2 years back I was pregnant, sir. I have given the birth to the one male boy, she told. So doctor advised you to give the TD1 and TD2 after the 4 weeks. So whether you are going to give or not? Yes, whether you are going to give or not. So she is telling last 2 years back only she got pregnant and that time she taken the TD1 TD2 both. Okay, so whether you are going to give, no need of the TD1 TD2 both again, just we are going to provide the TD booster if she got pregnant within 3 years. Very nice. Okay, yes, very nice. The next question is, hepatitis B vaccine should be given within how many hours of the life in a newborns? Hepatitis B vaccine within 24 hours we must and should give. So that's very important. Very important. Maximum time where we can administer the BCG vaccine is maximum time within 1 year we are going to provide the BCG. Now tell me, a child of the 6 month we are providing the BCG. What is the dose? Option A 0.05 ml, option B 0.5 ml, option C 0.1 ml. So what is the answer? BCG vaccine in a 6-month baby. (0.1 ml intradermal. So that is very great. Okay. So less than 1 month 0.05 ml and more than 1 month up to the 1 year 0.1 ml. So that is the dose of the BCG. Okay. Yes. Among the given 4 vaccines, which one is the killed vaccine? Option A BCG, option B measles, and option C JE, and option D hepatitis B. Yes, choose the correct answer. I know this question is confusing and very confusing, so you have to choose the very perfect answer. Okay, so now very simple. Which of the following is the killed vaccine? So first one is the OPV, BCG. Okay, then JE and hepatitis B. Which among the four is killed one? Killed vaccine. Remember, OPV is always a live vaccine. IPV is the killed vaccine. OPV is the Sabin. IPV is the Salk. BCG is always on the live vaccine. And JE we have the live plus kill both. So we will consider the live only here. Okay, but hepatitis B we don't have the live and kill. Hepatitis B only we have, that's the killed vaccine. Okay, so here the correct answer, which among the following is the killed vaccine, the perfect answer goes to the hepatitis B vaccine. Getting the point? Yes. So this is how we are going to eliminate the options and we are going to choose the correct answer. Right? Very perfect. So next question is, what is the site and route of administration of the birth dose of the hepatitis B? Site and route of administration of the birth dose of the hepatitis B vaccine is my question. Route is the intramuscular, very nice. And site is a left lower, like in the lower leg, that is in the anterolateral aspect of the mid thigh. So that is the left side. Okay, so which side you are giving the BCG vaccine? Same leg you give the hepatitis. Same side only you give the hepatitis B vaccine. Getting the point? Yes. So which among the following vaccine we can't administer through the intramuscular route is my question. The options are. The question is very, I hope it is clear. Which of the following vaccine we should not give by the IM route? Okay, so option is Penta we have as the A option, and B option we have is the hepatitis B, and the C option we have, that is the JE, and D option we have, that is the MR. Yes, which vaccine we should not give by the JE? You consider this is JE killed. Okay, yes. Which one we can't give by the IM route? Penta we can give by the IM route. Yes, sir. The route of choice for the Penta is IM. Hepatitis B, sir, IM. JE, sir, killed JE is IM. Live JE is subcutaneous. MR, sir, subcutaneous, not IM. Getting the point? So these are the very important points. I hope you enjoyed and you learned the things. Okay, that makes me to feel proud, so that you understood the things. Okay, yes. So next is here. Question is here. What is the main purpose of performing the shake test on the vaccines? We are performing the shake test on the vaccine. So what is the main purpose of performing this one? Option A, to check the potency of the vaccine. No. Option B, to detect the freeze damage in the freeze sensitive vaccines like a DPT and TT. Yes. The main purpose of the performing the shake test is to detect the freeze damage of the freeze sensitive vaccines like a DPT, TT, and hepatitis B. These are the freeze sensitive. If we are keeping this vaccine in the freezer, you have to discard that one because that will get damaged by the freeze sensitivity. Okay, so in order to check the freeze sensitive vaccine are potent or not, or the normal or damaged, so in order to perform we have to perform the shake test. What we are going to do in the shake test? In the shake test, we are going to perform the test like this. You can see the shake test. Here we are using the freeze sensitive vaccines like a DPT, hepatitis B, pentavalent, and the PCV, and we are shaking the vial. After shaking the vial, we are comparing a vial with a freeze destroyed controller vial. Okay, if in case after shaking the amorphous is not mixing with the fluid, the amorphous is coming and getting settled in the down and the fluid is very clear, that indicates the vaccine is damaged and we are going to discard that one. The clear fluid is coming, the clear liquid is there inside the vial, it is not mixing with the amorphous, so that is a damaged vaccine by the freeze, we will discard that one. After shaking, the white amorphous is properly mixing with the liquid and it is not clear, that is we are going to use. Very simple. Okay, but in your exam, how you will think clear means that is best to use, we will use? No, clear means the liquid is not mixing with the amorphous. Clear means the amorphous is going and settling in the down of the our bottle, so that is like damaged by the extreme cold. We are not going to use that one. Okay, shake the vial and compare with the freeze destroyed control vial, and the clear liquid is there means discard it, and white amorphous liquid is there means used it, you can use it. Okay, so very important, very simple. I hope it is clear. Okay, you can see while which we are discarding and while which are using. So after shaking, you see all the sediment is coming and like accumulating in the, all the powder is accumulating in the lower portion of the vial. It means the above fluid is clear. Above fluid is clear in the its sense the powder which is there here, it is not mixing with the liquid, means it is like it is not potent to use because it is destroyed. So this one we are going to discard this vial. Okay, so this clear vial I am going to discard. We can see we can use. So after shaking, it is well mixing. So this all the powder is properly mixing with the liquid. So this is we are going to use. Okay, don't get confused in the exam. Clear means we will use, and like cloudy amorphous means we are going to discard. No, cloudy amorphous means powder is properly mixing, so that is we are going to use. And clear means powder is not mixing, it is getting settled and sedimented in the lower portion of the vial, so that is discard vial. Okay, so I hope it is clear, right? So this is about the shake test, and shake test is very important for the exam. Already asked question in the exam, please do keep in our mind. Okay, yes sir. So next is very important word for you all. Dear aspirants, if you want to do something in our life, come out of the comfort zone, because the growth in the life will never ever coexist with the comfort. So in the comfort, growth is very slow and very slow. So if you want to be a growth and if you want to be success in your life, so please do come out of the comfort zone. Yes, some people will say, sir, we are unable to study in the home because we have the disturbances. No, that is depends on you. So you make your good room in the home and you request your parents, I want to study. As per me, there is no parents in the world, if you want to study and they are coming and disturbing you, that is like according to me, that is on the foolishness. Okay, so they will never ever disturb you, especially our parents. They will give the tea, coffee, whatever you want in your table, they will serve on time, and they will motivate you and they will tell you, you read whatever may be the result. Okay, so that is how you are coming out of your comfort zone, reading in your home within your exam, like you are keeping the mobile in front of you or the laptop or the tablet in front of you, and you are reading continuously for 2 hours, 3 hours without getting out of the table. So that is what you are sacrificing your comfort, and there your growth will start. And you are studying the our class and whatever the class, online, offline, whatever it may be, if you are coming out of the comfort zone, you will definitely win your life. Okay, because so the sacrificing the comfort is the main key for the success and the growth. The thing is difficult, but it is helpful in the future, right? Yes. So growth and comfort do not coexist. Both are not of friends, both are enemies. Please do keep in our mind. Okay, yes. And here it comes to the already discussed question previously. So this is for your assignment. So that is, what is the recommended daily dose of the vitamin D supplementation for a healthy newborn? Okay, so at that term, so along with this one, I want the answer of the zinc dose as based on the age group, and I want the answer of the vitamin D dose, and I want the answer of the very important, that is our albendazole dose. So these three answers I want in the comment box. So these three are the assignment to you all. So that is the mention A and mention your answer, mention B, mention your answer, mention C. In front of this one, you mention your answer. Okay. Yes, zinc, vitamin D, albendazole dose I want in the comment box of this class. So we will meet again with a very beautiful question in the tomorrow session. Tab tak ke liye, Jai Hind, Jai Bharat. Keep learning and avoid all the negative peoples. Like peoples will say, I am writing 6th time, 7th time, I am attending the Norcet 1 to till here, I have not cracked like this. So the people will they will not plan their things. They will just study one day, like 15 day, 20 day before the exam. They will fail in the exam. So those kind of the negative peoples, they will be a negative for self also, they will be negative for you also. Yes, if possible, you motivate them. Sir, this is not a technique of the study for the exam. If you want to crack the exam, take a 6-month course properly, study it properly, complete it, take a notes, and keep that notes for your revision at the end of the exam. Revise that perfectly. Definitely your success is there in that one. So you tell to them, they will get motivated. Okay, yes. So who are preparing for the Norcet 11 and 12, so we have the beautiful courses in our very important master nursing classes. Yeah, that is the plan A1, properly designed classes, PDF notes, subject wise test, topic wise test, daily live test, many more things that you require for your success, with complete 100% mentorship from my side. So please do join the A1 course for your bright future in the Norcet 11 and 12. Thank you so much for watching the video till here. Bye bye. Take care. We will meet again. Jai Hind, Jai Bharat. Thank you so much. Tomorrow, again, don't miss the class. I will be there for you all to cover the at least most important topic very perfectly. Okay, yes, we will meet again in the tomorrow session. Tab tak ke liye Jai Hind, Jai Bharat. Take care.